Here's an example of hydronephrosis. People often talk about different grades of hydronephrosis, and the higher grades being more obvious. This would be considered grade 1 hydronephrosis, where the individual calyces are dilated and hypoechoic. And this can be confused with a normal kidney in someone who has prominent renal pyramids. The way to figure that out is to compare one kidney to the other, and especially in younger patients and babies, you'll often see the pyramids look very obvious, and if both kidneys look the same, then that's probably normal. If a patient has unilateral symptoms and very prominent calyces on one side, that's probably hydronephrosis. With higher grade or grade 2 hydronephrosis, the calyces will be dilated and also the renal pelvis will be dilated, and people often refer to an image like this as a bear paw or bear claw, with the bear's toes being the individual calyces and the middle of the paw being the pelvis. Higher grade hydronephrosis causes the calyces and the renal pelvis to all become one contiguous structure, and the individual calyces are not visualized. As hydronephrosis gets more chronic and more severe, you'll notice that the cortex becomes thinner, and so in longer standing or very high grade hydronephrosis, the cortex will look very thin. Here's an example of a less common finding. There's fluid around the kidney and completely surrounding it. So this is the liver here, but this fluid's not in Morrison's pouch, it's surrounding the entire kidney. So this is an example of a ruptured calyx from a renal stone obstructing the ureter. And the significance of this is not too great. It'll unless there's an infection present. You can also see similar things with bleeding around the kidney with a trauma patient. This is another common finding. This is a patient with renal cysts. So there was one here, and as you scan through, you see another one at the lower pole, coming off the lower pole of the kidney. This one is very well demarcated and clearly anechoic inside. And then as you scan through here, you see a third one. This one is not as well demarcated, a little irregular around the edges, and has a little hyperechoic or echogenic material in it. So when I see renal cysts, I will often note whether they're simple and well demarcated, but I always tell the patient to follow up for a repeat scan and follow up with their regular physician to get further confirmation that there's just benign, simple cysts, because you don't want to get these confused with malignancy or abscess. Here's an example of a patient with, this is a long axis of the kidney, and there's this structure here that's well demarcated, but it has quite a lot of echogenic material in it, and this can represent either an abscess or a malignancy in the right setting. So you don't want to get a patient with this problem confused with a simple cyst. So that's not really our job, and so it's good to have these patients follow up. When you start looking at the bladder, what you mostly want to determine is whether the bladder is empty or full. This is an example of a patient who couldn't urinate, thought he had a full bladder, but actually his bladder is almost completely empty. So you can measure it, or you can just look at it and say it's very small and empty. When the bladder empties, the wall looks thicker. This is an example of a similar patient, but this patient had a full bladder. So again, you can measure it, or you can just look at it and say that's very full and the patient needs to be catheterized. Sometimes you see prostate. The prostate should be down here and much smaller than this, and this prostate is pushing up and kind of protruding into the bladder, and that's a common finding. Again, not usually an emergent problem, but you should have the patient follow up and tell them they have a big prostate. And it's also easy to see Foley catheters and other structures inside the bladder. This was a septic patient who had an obstructed Foley catheter. You could see the Foley balloon and the Foley catheter, and you could see debris floating around when the catheters moved. And so this catheter either needs to be unplugged or changed out. And this was actually, when this was changed out, this was essentially pus inside the bladder, and this patient was septic because of the Foley obstruction.